With that, I think that's everything. If I remember anything else, I will let you know. Any questions on that? It's definitely Friday. You guys are all almost comatose, I know. Your brains have about had it for the week. Let's go ahead and get back to our lesson here, guys. We'll go more into some of these vital signs this morning. Get everything pulled up. Whoops. There we go. Okay. So last we left off, we were just defining some of these terms right here, some different conditions that can occur with people's breathing. We left off on apnea, which would be the complete cessation of breathing. Now, we do look for some certain signs when it comes to apnea specifically, because obviously that would be the worst of all those named conditions right there, because cessation of breathing, you're essentially dying. We have to induce CPR very quickly. So if you ever see certain signs on patients that are presenting with apnea, it's something we got to react to extremely fast, because lack of oxygen to the brain is going to cause brain damage very quickly and very fast. So we need to get that oxygen flowing back quickly and efficiently as fast as possible, either with CPR, a machine, whatever we got to do to get that patient back regulated and back in that homeostasis. So one of the things we look for is definitely one of the biggest signs is you're going to see someone start turning blue. When someone's turning blue, that's what we call cyanotic. That is a very definite sign that that patient is not getting oxygen at all or very, very little oxygen. And primarily what's going to turn blue is going to be the lips, the fingers, and the toes. And that's for adults and babies. You can see a picture of a baby right here. That is something we look for because that's going to be a very surefire sign that that patient is dying very quickly. They're apneic and they're going completely blue and cyanotic. If you've never seen that before, it can be quite scary. And people really do turn blue when they're lacking the oxygen. The fingers do get very blue, the lips, the toes, just like you see in that picture right there. Quite common in a lot of trauma patients that come in that are having a lot of issues breathing. Also very common in pediatrics because a lot of babies do pass away due to apnea. People don't catch it in time. And that's just some real pictures there to show you that they actually do turn blue. There's some blue hands, the blue lips on the baby and the adult there. So if you ever see that on a patient and someone's not reacting to it, you as a medical worker, that's something you need to immediately call a code. When you call a code and people start rushing in, you got to start CPR fast, get them hooked up to a machine, get that oxygen delivery going really quickly and really efficiently to help reverse any kind of permanent damage to that patient. Because the brain will suffer quite a bit of damage with a lack of oxygen going to it. So time is the issue. Once again, if you ever see that, you need to immediately react. Don't go and say, hey, nurse, I'm going to think your patient's blue. You might want to come check that out. That would be the wrong reaction. You're going to say, someone call a code immediately. I need some assistance. We need to perform CPR immediately. This patient's turning blue. They're cyanotic. Start doing CPR right away while everyone's bringing the equipment in to get that patient re-regulated and back to that equilibrium state. So we're going to talk a little bit about pulse here moving forward. Pulse is something else that we're going to do as far as vital signs, and something else that we got to recognize should we ever recognize there are abdominal pulses in our patients. The first thing here, we're going to talk a little bit about the cardiovascular system. Not too much in this chapter, but when we get to our next chapter, we're going to really dive a lot deeper into the cardiovascular system. We're going to talk about the chambers of the heart, where the electrical charges are coming from when the patient's heart is beating, diastolic, systolic pressure. We're going to talk a little bit about those EKG charts. Yes, we're going to learn all the letters on those EKG charts, but not so much in this chapter. That's coming in the next chapter. We're just going to do a brief overview a little bit leading into that. So one thing to remember when we talk about the cardiovascular system itself is what we call a closed-loop system. In other words, it does not terminate at any point. Your blood flows in a continuous loop throughout the entire body from head to toe. It's a completely closed loop, so to speak. So we do refer to it as a closed-loop system. As you can see that picture right there, that's not obviously a representation of the entire body. But you got your heart in the center there, filtering all the blood in and out, pushing it through the rest of the body. All those veins, all those arteries are within that closed loop system. If they're not, blood will be leaking out all over the different cavities of the body. We need that to be closed loop, because as the blood loses oxygen, it's got to go back and be re-oxygenated, so on and so forth, as it flows to the body. We're going to get more into that in the next chapter of how that all works. But it is that closed loop system. So when we talk about pulse, ventricular contraction particularly, it's going to be transferred to arterial walls, and it actually permits the ability for us to have what we call a pulse measurement. So we're always looking for that ventricular contraction to make our pulse reads, whether we're looking at the diastole or the systole. Now, diastole, when you hear the word diastole, that's referring to a filling of the ventricles. In other words, blood is filling in the ventricles. When we talk about systole, that blood's actually being pumped out of the ventricles. And we are making measurements on both of those different systems of contraction within the heart, with this diastole or systole. That's why we always have like a 90 over 180, so on and so forth. You always get those two readings because you're looking for those both processes to happen on the pumping of the heart within those ventricles. But do remember, we do. Yes.
Can you repeat the DS? I can't pronounce that. Diastole?
Diastole refers to, yes. Diastole refers to ventricular filling. In other words, the blood is filling the ventricles. Systole refers to ventricular pumping. It's going to actually pump the blood out of the ventricles. And we base our pulse measurements primarily upon those two acts of contraction within those ventricles. We're not going to measure the atria. You have atria and ventricles. We're going to measure the ventricles primarily for pulse. A lot of people make that mistake. They think it's every chamber of the heart that we're reading. We're actually only reading what's going on in those ventricles primarily when we take pulse. So,
Thank you.
Oh, yeah, go ahead.
She said thank you.
Oh, you got it? Okay. So when we do measurements of pulse, the three most common, that does not mean the only sites of measurement, by the way, the three most common sites of measurement are going to be our radial artery, which lines up with your radius. You find your thumb, go inferior to your thumb, your radial artery's right there. You've probably done that before when you measured a pulse. Excuse me, the brachial artery, you see right down here at your elbow, and the carotid artery, probably the one a lot of people are most familiar with. If you take a pulse, put your finger on someone's neck, that would be your carotid artery. That's the three most common sites of measurement we're going to use for actual pulse measurements. Usually when we're doing that manually, by the way, like we're putting our fingers on the veins, that's what that's referring to. It's not exactly referring to the blood pressure cuffs. We're going to talk a little bit about those in a little bit. So radial, brachial, and carotid arteries are the three most common sites of measurement. And that's going to be part of the things that you do on your practicum. Whenever we do that practicum, you're going to actually work with one of your classmates and go ahead and take their pulse manually using your fingers. But you'll also learn how to take the pulse using the blood pressure cuff with the stethoscope as well. We're going to learn both ways. Two different methods. And there's someone just doing a radial pulse right there. Okay, so for pulse rates, the count rate is 1 minute for each heart contraction. Once again, talking about that ventricular contraction. And if you remember, that average pulse rate on adult is going to be 60 to 100 beats per minute, versus a child is going to be that 70 to 120 beats per minute. So repeating those numbers again, do make sure you know those numbers. You're going to see that. Big star, hint, hint. You're going to see that. You're going to see that. You're going to see that. Not just from me, but on the registry as well. 60 to 100 on adults, 70 to 120 on children. That's what's throwing me off, Jess Lee. Usually you're like, you got like a red background and it's gray today. I was like, something seemed off about this picture right here. You see all your pictures side by side? Like, something's throwing me off. I don't have that red room I always see. We changed locations. We mixed it up today.
Yes, sir. Yes, sir.
Okay, that's all right. I keep me on my toes. It's those little details, they stand out to me. Those little tiny details.
It's like, how did it go from pink to this?
Yeah, it's quite jarring. Quite jarring. I've gotten used to your background. Most of you have a very consistent background during class. So, all right. So we're talking about pulse measurement some more, guys. So very important thing to remember: when we are talking specifically about CPR, that pulse will be typically measured at the carotid artery. Not always. Like sometimes they won't be able to find a pulse at the artery. The carotid artery might choose another location. But the most common site for CPR specifically would be that carotid artery, especially in trauma rooms. You'll see them immediately put those fingers on the neck and start trying to get a pulse very quickly. Hopefully, everyone here does have a pulse this morning. You might want to check it out. Make sure you are awake this morning. I do hope. I mean, you're all sitting upright, so I assume nobody's dead this morning, but that can be debatable.
That's
especially
debatable.
on a Friday morning.
That's debatable.
But I'm assuming everyone is alive and well and has a nice pulse this morning. I feel like I'm dying. I just got that in the comments. Thank you for your honesty. Oh, boy. Okay, so pulse oximeters. We will see these a lot of times when we go into patient rooms, especially the EC. Also on a lot of children patients. A pulse oximeter most typically is going to go on the patient's pointer finger. It can also go on other fingers, but most commonly it's going to be on that pointer finger. Now, what that does exactly is it's going to measure the hemoglobin and the oxygen saturation of arterial blood, not venous blood, arterial blood. And at the same time, it's going to go ahead and measure that patient's pulse rate. So it does have a dual purpose there. Oxygen saturation of arterial blood and that patient's pulse rate. And most commonly, that's going to be on the patient's pointer finger. It can be on other locations as well. Where else might we put that pulse oximeter besides the phalanges, by the way? Fancy words, phalanges.
Is it on the toes?
Yes,
The toes.
the toe. And I kind of misspoke there because the toes are referred to as phalanges as well, so it was a little confusing there. But if they choose not to use the fingers, and most of this is with babies, they're going to go ahead and put it on the toe. And the reason for that is a baby, of course, is not going to sit very still, and they're going to be pulling at that pulse oximeter. So they're going to actually put it on the baby's big toe and go ahead and tape it on there very tightly so they don't lose any of those reads on the NICU baby. Has anyone got to go to NICU yet, by the way? Nobody? Couple of you? Well, as Betty, you don't count. You work at Texas Children's. You'll see a lot of those pulse oximeters in NICU. That's why I brought that up on all those little babies' toes. So like,
can they do it on the ear?
Say again?
Can they do it on the earlobe too? Isn't that a site as well?
Well, let's look at our slide right here. Yes. Yes, an earlobe is an alternative location, but most commonly they're still going to stick to the fingers or the toes. But there are some alternative locations right there in the middle. Like Jonathan just said, earlobe can be another place to put a pulse oximeter. Not very common, but every once in a while they may do that. Now for infants, the most common location, like I just said, is going to be putting that probe on the big toe. It's the most secure location for a pediatric patient. But alternatively, they may go ahead and put that on the earlobe, temple, sometimes the nose. I don't think I've ever seen it on the nose. And just on the foot as well. So how does that work exactly? Well, it's actually using an infrared light. And what it's doing is to find the oxygen levels, it's converting the light intensity into actual oxygen saturation and also converting those pulse rate values to give a readout on that computer screen that the nurses can keep track of to make sure the oxygen saturation is at a nice equilibrium homeostatic level. And that pulse rate is also nice and regulated at a nice even rate. So it's converting that light intensity. That's how that works. We won't go into all the physics exactly how that works, unless you really want to know. But I know everyone just loves hearing physics this early in the morning. But just make note, it's converting that light intensity into that oxygen saturation and pulse rate values. Don't worry, I promise you'll get all the physics you ever dreamed of next semester.
I'm good.
Not from me, though. It's not my class. And that's what that would look like, guys. There's that tape, and you will always see that tape to the baby's little toe, little big toe. And once again, that's to keep that secure because babies are notorious for ripping those off. And that's if they rip it off, you're going to hear all those alarms buzzing and going off. Everyone's panicking, like, oh my God, the baby's dying. No, most often what's going on is that baby just pulled that pulse oximeter off and they're not getting any read at all. So go ahead and secure that real tight so it does stay on that baby's toe. And speaking of big toes, I'm jumping ahead a couple of chapters in Rad Pro here. There is an alternative name for the big toe that a lot of doctors will use in the hospital. Does anybody know what the alternative terminology for a big toe is? And not phalange, not first digit. There's another word for it.
Is it Pollex or Pollex?
You are very close. You are very close. It's hallux. 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 Very good. Very good. You almost had it. You just had one letter off. It's a hallux. So if you ever hear the doctor talking about the hallux, they're referring to the big toe. Now, what can affect the accuracy on these reads? Of course, movement. The patient is moving around quite a bit. It's not going to give you a nice, even read that you're hoping for. Loose or misplaced probes, that's also the importance of making sure it's taped very securely on children. Adults, most of the time, it's just going to be using that clip. It's going to stay on well unless the adult's just misbehaving, not doing what they should do. But that being loose would obviously not give an accurate read. Nail polish and acrylic nails are actually going to interfere with it as well. They would go ahead and use one of those alternative methods if a patient does have those nails because they're not going to get a read at all. And then low blood pressure and poor peripheral perfusion would be another reason that affects accuracy of those reads. Okay, so if a patient is going into cardiac arrest, we're talking about pulse still here. If cardiac arrest does present in the trauma room or wherever in a hospital, that carotid artery is also going to be what's assessed first. And we're going to assess that for a full 5 seconds to try to find that pulse. And they're going to do that specific number because if they go beyond that 5 seconds and there's no pulse, that's code for we got to immediately start CPR very fast and get that patient resuscitated. It's 5 seconds. Every once in a while, like if you put your finger on someone's neck for a second, sometimes people's hearts skip a beat. That's not an accurate read. You're going to do that full 1, 2, 3, 4, 5. If there's no pulse, they're going to say no pulse, begin compressions, or go ahead and defibrillate. And put the stickers on them and shock them. But it's going to be that full 5 seconds using that carotid artery to assess that pulse. Anybody here been able to go to the trauma room yet and see cardiac arrests at all? Anyone been in the trauma room period? Or the shock room, rather? They call it shock room here. A couple of you? No one's seen cardiac arrest yet? Will eventually. At some point you will. And everyone, including you, is very involved in trying to get that patient back to life. We have a very intense thing to experience.
I saw a gunshot wound, but that's the thing that the most I've seen.
Okay, save that story for Rad Pro. We'll do some story time. I want to hear about that. Yeah, I saw a guy that one of my first semesters got shot in the head. He passed away. He had half his head blown off from a gunshot. It was quite intense. I saw some pretty insane stuff when I was a student. Well, and even in my career as well. So electrocardiogram, guys. So this is going to be kind of overlapping in the next chapter as well. We're going to go far more detail on electrocardiogram specifically in the next chapter. But what to know for now on this one is that we're going to use either a 6 or 12 lead ECG. That is the abbreviation ECG for electrocardiogram. You'll also sometimes see it referred to as an EKG. So we will use a 6 or 12 leads. I prefer the 6 because those are the easiest ones to put back on. The 12 ones are a nightmare unless they have nice color-coded stickers. And they do not always have color-coded stickers, just to warn you. So what does that do? It's using actual electrodes to monitor those heart rates and rhythm. It's going to give that printout with all the little up and down hills and valleys, those little squiggles that you see on those heart rate charts. And it's going to monitor that electrical activity of the heart and transform that activity to the pulse rate values and those waveforms. And we'll get that nice printout on that EKG sheet. Make sure there's no arrhythmias or irregular heartbeats going on. We're going to get those P, QRTs, Z waves going through that EKG. We are going to learn to read a few of those in this class. Not in extreme detail, but just a little bit, just so you know what you're looking at. And just guys, when you're ever dealing with these kind of patients, so obviously what I've told you before is when we do a chest x-ray, we don't want those leads in the chest. That presents as an artifact. It's going to cover up the anatomy. So typically we're going to go ahead and remove those leads. And once again, that's something you always got to ask first, like, hey, nurse, is it okay if I take the leads off the chest x-ray? Most of the time they say yes, absolutely. If they say no, you document you had to leave them on even though you asked. But with that being said, don't be one of those techs that you take the leads off and you walk out of the room without putting them back on. That is the worst reputation for you, and that makes us as techs look really bad, and nurses have a huge pet peeve on that. I know I speak ill about nurses quite a bit. At the same time, we got to try to unite a little bit. And you know what? If that patient's having a cardiac issue, put the leads back on. They may be having arrhythmia after your chest x-ray, and they may not even detect it because you didn't put the leads back on. So always reconnect those leads. And what's nice is most of the time these days, they have those leads color-coded. So each lead will be like red, green, blue, yellow, brown. And the stickers will also have the colors. And you can just match them to the stickers. Very easy. But then if they don't use the color codes, it's a little bit of a nightmare. Don't guess and just randomly put leads on that patient, because then they're going to start seeing all kinds of crazy stuff on that screen and think the patient's dying. If you just can't figure it out, let the nurse know. Say, hey, I took the leads off, but I'm not quite sure how to reconnect the leads. I'm just letting you know so they can get their EKG run again. All about that communication once again. And there's what a typical readout would look like right there. We are going to learn how to read that, by the way, in the next chapter, the PQRT waves, and know what's normal versus abnormal. I'll tell you a little bit about my wife's condition as well when we get to that chapter, because my wife has a condition called long QT syndrome. It's talking about the QT wave. It gets prolonged on her heartbeats, which is why she has to have a defibrillator regulate her heartbeat. But I'll save that for the next chapter. Down there on the bottom is what I was talking about. Most of the time they will be nicely color-coded, like you see right here. And go ahead and you just match the color of the lead to the sticker. And you'll make sure you have that connected back properly. They do have to be very precise, or it's not going to do the proper reads with the leads. Reads with the leads. I'm making some rhymes here.
Did we take off the stickers when we're doing a chest x-ray, or do we leave those on?
Typically the golden rule on that, that's a good question, by the way. Typically the golden rule on that, Jaleisha, is if you're doing a portable x-ray, we go ahead and leave the stickers on. But if they come to the department, we go ahead and have them remove the stickers completely. Because in a department, you're expected to get a much higher quality x-ray versus a portable, where you got a little more leeway for artifacts and things not being top quality because you are doing a portable patient. So portable, leave them on. Coming to the department, make sure they take them off. And that's a good point to bring up as well. When we talk about these leads, I think you guys remember me saying from last semester, one of my biggest pet peeves is the nurse will always send your patient down to the department with those leads still connected to their chests, and they won't take them off. And we'll hurry up and do our chest x-ray, and also we got leads and stickers all over the chest x-ray. We got to repeat the chest x-ray. So when you're doing your AIDIT, when you're doing the dressing instructions, always go ahead and chime in and say, hey, I just want to make sure, did they put any stickers on your chest? Because don't say, did they put an EKG on your chest? A lot of people don't know what that is. So did they put stickers on your chest? Everyone knows what a sticker is, and they'll know what you're talking about. They can go ahead and remove those, and you can get your nice quality x-ray. Okay, so blood pressure. We're going to talk a little bit about that blood pressure cuff. And when the time comes, I will demonstrate how to properly do this. Everyone's going to learn how to do this as well. We got a lot of really great blood pressure cuffs at the school and stethoscopes. Jeff, a question? Jessley? Saw you raise your hand.
Are we going to do the electronic? So we're going to do electronic too, right? Not just manual, both?
You talking about the blood pressure?
Yeah.
Yeah, you're going to do it manual with your fingers, and you're going to learn with the blood pressure cuff, both ways.
So, but with the electronic machine, though?
Oh, no. Unfortunately, no. We make you do it the old school way. I'm sorry. No electronic ones, unfortunately. And that's a good point to bring up as well, though, Jesse. You will see a lot of the pulse is done electronically these days. You've probably seen the ones you put on your wrist and you hold it up to your chest. It's probably the most common you guys are familiar with. By the way, those are not very accurate. But, I'm so sorry to disappoint you. We're going to do it the old school way. Yes.
So, Mr. Donahue, I have, we have the electronic blood pressure. What if I just bring that? Like, if I'm
Nice try. I appreciate the effort. Nice try, and I appreciate you offering that. But we do have to instruct you the old school way per ART. So not my call, but that's the ART requirements. So I'm so sorry.
I try to help.
I know. Yeah, I appreciate it. I appreciate you going that extra mile. Okay, so a little bit more about respiration assessment, guys. This picture here is showing, once again, the movements of the diaphragm and lungs when we're breathing in and out. What I want you to remember on this picture in particular, because you'll hear a lot of nurses and doctors refer to this, whenever we are making an inspiration, that's referred to as positive pressure in the lungs. When we make an expiration, that's referred to as negative pressure in the lungs. So breathing in is positive pressure, breathing out is negative pressure. Respiration specifically.
And it was on the 16th. And Wednesday too. We have Wednesday too for.
So ventilation, we will encounter a lot of patients. We'll say patients. A lot of patients on ventilators. Those that can't breathe on their own. They'll be on all kinds of apparatus and machines doing that breathing for them. And the main point of that ventilation is allow those diaphragmatic muscles to do their work properly. It's going to be that moving downward, moving up, pushing the air out, letting it come in during relaxation, expanding the chest cavity properly, and all that entire process of obtaining that negative versus positive pressure in those lungs. That is going to be done by those ventilation machines should a patient be unable to breathe on their own in a natural sense. So a lot of this we already know. It's just talking about that movement of the diaphragm, how the lungs move, how they expand and deflate, how the chest cavity also expands and relaxes. But in this instance, we're just referring to that ventilation or ventilators that a lot of patients will be on. It's going to do that job for them, essentially. And be very careful around those types of patients, because same with like the chest tubes, things we talked about, those machines can take up quite a bit of those rooms. You'll be doing portable x-rays, and some of you already know by now with the portable machines, they're quite bulky. Sometimes they can get away from you if you're not careful how you're pushing them. Even though a lot of them are self-pushing, they can get away from you. And I mean, my God, one of the worst things that can happen is if you are not paying attention, your machine hits one of those ventilators. I mean, you're going to cause a whole domino effect of disaster in that room. So we got to be extraordinarily careful around these types of patients because they are in extremely critical condition. And the only thing keeping them alive essentially is that machine. Especially if you ever do ECMO babies, you go into the NICU, they have a lot what's called ECMO machines breathing for these babies. And these machines take up almost the entire room. They're humongous. There's just hundreds of wires. A little baby that's about as big as the palm of your hand, keeping that baby alive. So we got to be super, super careful, be really aware of our surroundings. This here is just restating that definition from earlier, guys, that tidal volume. It's going to be the amount of air that's exchanged under just a normal condition, just that normal breathing. We measure that with the breaths per minute, BPM, and we refer to tidal volume as a very accurate measurement for breaths per minute. So a lot of times these breaths per minute will be recorded as a tidal volume because we refer to that as a very accurate measurement of those breaths per minute. So it's that normal breathing. We're going to make that normal breathing reading. We're going to refer to it as tidal volume. It's very accurate. And like we already stated, it's going to be measured in those breaths per minute, BPMs. Ooh, I apologize. My voice is going out today. Season changes, man. That wrecks my allergies. So for blood pressure measurements, so what are we measuring exactly when we talk about blood pressure? Doing that blood pressure cuff with the stethoscope. We're actually measuring the force that's exerted on the walls of the arteries, not the veins, by the way. We are measuring the walls of the arteries. During the cardiac contraction and relaxation, we're still basing that, by the way, upon ventricular contraction and ventricular relaxation. Very important to remember that once again. We're not doing atrial, we're doing ventricular. It's going to be two values, systole and diastole. If you don't know how to spell those, it's coming up on the slide here in a second. And it does require two pieces of equipment. Talking about the old school way, once again, not the new digital way that Jessie was referring to. And those two pieces of equipment are going to be the stethoscope and the blood pressure cuff. Some blood pressure cuffs will come with a stethoscope attached to it, but not all do. And each of those blood pressure, she has said the easier method in the text there. I agree, by the way. Those blood pressure cuffs will also have a dial on it where it has that little meter so you can see the numbers and make those readings. And we'll learn how to do that. And it's not my preferred method either, but we do have to still teach it to you. By the way, what is the fancy way of saying a blood pressure cuff? It's a very long word. You guys remember that?
Nope.
You mean the sphygmometer?
You're close. Sphygmomanometer.
Okay.
You're missing a couple syllables there. Sphygmomanometer. Yeah, but it's much easier to say blood pressure cuff. Okay, so blood pressure cuff here, guys. That's obviously a little drawing of what that's going to look like. I think we're all familiar with what that looks like. Now, very important, we are always going to put that cuff over the brachial artery. And it's always going to be right above the elbow. If we do not put that blood pressure cuff in that location with the old school blood pressure cuff, we're not going to get an accurate reading at all. It's going to be very, very off. Excuse me. Now, those newer ones will do those measurements at those ulnar and radial arteries, but when we're talking about these old school ones, we're going to go ahead and still stick to using that brachial artery. So we're going to inflate that cuff full of air until it's really tight. Most of you know how that feels. It's going to feel like your arm's about to fall off. We're going to slowly release the air out of that cuff, and we're going to place our stethoscope on that brachial artery. We're going to listen very carefully for that pulse rate, and there's certain sounds, certain things that we look for when we're making that measurement. And we're going to go more into detail on that when I actually do a demonstration. I'll show you exactly how that works, and you'll all be experts at it by the end of this semester. We'll figure out when we're going to do that. So we release the air in the cuff until the pressure in that cuff matches the systolic pressure, and when we're listening to those sounds, when we don't hear any more sounds, we're listening to that beat, by the way, that little thumping sound, sounds like the heart beating. When we don't hear sound anymore, that's when we know we can record the diastolic pressure that has been reached officially. That's not making a lot of sense right now. We're going to do that in actual demonstration. It'll make sense when you actually perform that on a live person. Okay, so this is kind of going to what Jessie was referring to. I'm going to keep picking on her for bringing that up. So blood pressure can also be measured and displayed through our cardiac or vital signs monitor, whether it's that pulse ox, whether it's an EKG. It's also going to measure that as well. We do have those automatic cuffs as well. Yeah, go ahead. We do have those automatic cuffs as well, the ones that go on your wrist. That, every time I go to the dentist, they go ahead and do my blood pressure with that blood pressure cuff. And they always say my blood pressure is terrible because I always get really nervous when I go to the dentist because I hate having my teeth picked at. And my blood pressure is always kind of high. But they also say at the same time, these blood pressure cuffs are so inaccurate. So we don't know if you have high blood pressure or not. Are you nervous? I'm like, yeah, I am nervous. I can confirm that. But those automatic cuffs are going to make a read. It should achieve an accurate reading like we would for a normal blood pressure cuff. But what I will say is for the most part, they're quite inaccurate. So I know Jessie loves those things. I mean, that's just her gold standard. But let me tell you, based on research, they are very inaccurate. The more accurate read would be the old school way or an EKG monitor with the leads.
I'm sorry. What makes them accurate?
What makes them inaccurate? Because the radial and ulnar arteries do not give as accurate a read compared to the brachial, and those cuffs on the wrists do not achieve as quite as much of a tightness as the ones on the brachial achieve, and just overall the technology just isn't quite there yet. That's what I've been told, at least. The technology just isn't there yet. They're still trying to advance that to make it more accurate. So overall, that brachial artery is still going to be a lot more accurate than those wrist monitors, even though a lot of people are using them today. But it does go, the one that goes on your wrist still is going to go on that inflating and deflating principle to make it inaccurate read. It's not close enough. It's inaccurate. Jessie sending me text messages on the chat here. So overall, the main point though, guys, even though we have some of these automatic ones, do keep in mind still the most accurate is going to be the brachial typical sphygmomanometer, blood pressure cuff that we use and put over that brachial artery. Go ahead. I saw you wanted to say something.
I forgot that. But it's still close. I mean, it may not be accurate, but it's close to what it is. To what it's okay. So mine was like I'm gonna say 130 by like 80, but it says like 110. It's still pretty close. It's still in the normal range, you know.
Well, so I don't know what planet Jessley's on, but I'm just going to tell you from my experience, these that we see right here on the left are very inaccurate. I mean, they're convenient. I'm not going to lie, they're very convenient, but they do give very inaccurate reads. And even the ones on the right, this is the automatic blood pressure cuff that goes on the brachial artery. A lot of hospitals use these. Even these still are quite inaccurate. The more accurate method is the manual method, still to this day. That's the main point there. So they're nice. I love them too. It's a lot easier. If you want that truly accurate read, you should opt for that manual method, which you will all personally learn how to do. By the way, if you do have your own blood pressure cuff, I know a lot of the students last year had one at home. You can bring that when we do the practicum. If you're more comfortable with that, that's totally fine. As long as it's not an automatic one before you say anything, Jessley. I know you already said that.
I was about to.
I know, I saw it all over your face. Jesse's like the star of the show today. I'm sorry. You started, you walked right into it. You only blame yourself.
But it was a good question.
It was a good question. It really was, because that's what we mostly see these days.
Exactly. And when you go to hospitals, they're going to pull out the electrical ones because it's easier. All you got to do is push that start button and push that stop.
But remember, guys, a piece of wisdom, easier does not equal better. Easier does not always equal better. Case point, in X-ray, most of you have seen technologists utilize the AEC function, which is the automatic exposure control that picks your techniques for you. Have you seen that? Yes. Mr. Donahue hates the automatic exposure control. You know why? It's lazy, it's sloppy, and it produces less quality X-rays at a higher dose. Manual techniques are superior, better images, and lower dose for your patients. But I'm getting into another class. We get to that on radiation protection. That's a year from now.
Mr. Donahue, you also said that you didn't like to, you know how we can digitally put the right and left marker? You also said you don't like that either.
I do not, because that could actually lead to a malpractice suit. Yes, you should protect yourself. Don't get lazy like those techs you're seeing in the hospital. There's a lot of lazy techs out there. This career field breeds a lot of lazy people, but you guys are not going to be lazy techs. You're going to be the best techs. If I have anything to say about it, you are. But don't be like them. Lead by example. It's going to be worth it, I promise. Okay, what was I talking about? I'm all off subject here. Let's go to oxygen delivery here. So that's another thing that we're going to see a lot in the hospital, guys. You're going to see a lot of patients on oxygen, whether with the nose cannula, with the face masks, multiple ways. So a lot of you may have seen these in the rooms, by the way. Have you guys seen these in your rooms, hospital rooms, the oxygen delivery devices? These allow us to have that continuous oxygen flow. By the way, don't go up to one of those and stick a tube in your mouth and start sucking oxygen like a lot of people do. That's not a good idea. I see you making faces, but yeah, people have done that. Students and techs. True story. They say they need some oxygen, so they suck some oxygen out of these things. Don't do that. You can actually get fired for that. That's a bad idea. These oxygen devices, Lord have mercy, I'm losing it today. These oxygen devices are going to operate, guys, with a measurement that we call liters per minute. Oxygen is measured in liters per minute. It's simplified to LPM. And most typically, they're going to be green in color. You see the green, that's usually going to label that oxygen. And that is different from air. That's disturbing. Yes, it is. You have no idea. The air is right next to the oxygen typically on the wall, guys. Obviously, if a patient needs oxygen, we need to know how to identify oxygen. If for some reason that was not labeled, you look for the green color. The green is going to label that oxygen compared to air. You'll also see another device typically next to those. It's a suction device that will actually help suction out fluids out of people should they be suffocating on liquids. They're usually all right next to each other, but you look for that color green just in case, even though it should be labeled, it is not labeled. That's our oxygen flow meter. And we do use those for emergency situations most often. Sorry, guys. I'm like, I can't keep a straight face. They've got me all laughing this morning. You broke my poker face. It's hard to do, you know? You broke my poker face.
It's not that hard.
I'm getting all kinds of stuff in the chat. Y'all don't know what I'm seeing here. Okay, so blood pressure measurement, guys. Let's talk a little bit about the systolic versus diastolic.
Yes.
So still talking about ventricular contraction, by the way. When we refer to systolic pressure specifically, what that is in definition, that's the pressure no longer exceeding our internal pressure. It's actually a contraction of the ventricular chamber of the heart, both ventricular chambers, by the way. And what we call the normal range on that systolic pressure is less than 120 millimeters of mercury. And the reason we do the millimeters of mercury is because those blood pressure cuffs do use mercury for their readings. Mercury, I can't even say the word mercury, for their readings. Now, diastolic pressure, when we define that, that's going to be the relaxation phase, by the way. The blood's leaving the ventricles. It's relaxing. That's when the blood flowing through the arm can no longer be heard. And when we actually demonstrate this live, you'll actually hear that through the stethoscope on the patient's arm. The normal read for that would be less than 80 millimeters of mercury. So a great question I could ask, guys, I could say, you know, a patient that presents with 140 systolic pressure over 80 diastolic pressure, is that normal? You would say no, because the systolic pressure is higher than the average. So that's the kind of questions I could ask on that. Make sure you know those numbers. And we do measure those once again in those millimeters of mercury. I don't know why I cannot say that word this morning, mercury. And on the periodic table of elements, that is represented by an Hg. You know, I don't know what these scientists were smoking when they came up with the periodic table of elements and why they put Hg for mercury, but unfortunately, that's what we go with. There are a lot of elements on the periodic table that act like that, like potassium's K. I mean, like, seriously, there's not even a K in the word. I don't know what they were smoking. I don't know what they're doing.
It's derived from Latin.
It's because of the Latin word. I actually did not know that. Thank you. It's based on the Latin word. So yeah, I learned from you guys too. Still, you know, kind of confusing. Okay, so 120 over 80, once more, that's our normal average systolic diastolic pressure. If that pressure is very low compared to that average number, they're going to have a condition that we call hypotension. If it's higher, they're going to have what we call hypertension. I always say the easiest way to remember that is if someone's jumping around really hyper, acting really energetic, their blood pressure is probably really high because their heart's beating fast. So hypertension refers to a hyperactive person. Blood pressure is high, blood pressure is up. There's that hypotension, which would be the lower than average numbers on that blood pressure. Ready? Quit trolling me in this chat. You know, it's Friday, though. We can have a little fun. It's okay. I like the fun, guys. Oh, my gosh. I'm so sorry. So big point here, guys. Big star. This is a question they may ask on your registry. I have seen this question on my registry. Oxygen is 100% considered to be a drug. We do classify oxygen as a drug. Thus, if a patient needs oxygen, we're not just going to start giving it to them. It actually has to be ordered as a drug, much like Tylenol or ibuprofen or whatever. It falls in that same category that if they need that oxygen, they're actually going to order that as a drug. Its characteristics is it's colorless, it's tasteless, it's odorless. Not going to see it, not going to taste it, not going to smell it. But we do need that for our essential life processes. When we talk about the atmosphere itself, oxygen does make up 21% of the overall atmosphere. I'm so sorry. I am so sorry. Y'all stop chatting me in the chat. Y'all making me laugh today. It's not flammable. It's not flammable at all. It supports combustion. In other words, if you lit a match in a room with oxygen, you're not going to blow the room up. Although, be careful on that, guys. If you remember back to that picture I showed you with those oximeters on the wall, a lot of techs or nurses, if they use those in the room, they'll leave those turned on. Sometimes you'll hear that sound in the room, like you hear like a sss. If you ever hear that, go look on the wall and make sure you turn that off. because that's costing the hospital a lot of money. And I mean, it's not like it's going to really hurt you exactly, but go ahead and turn that off. Don't let that just keep running. A lot of people leave those going. So a couple of
Miss Johnny, I have a question.
yeah, sure.
Probably a dumb question.
No such thing.
Can you overdose on oxygen? Like if it keeps on running?
Sorry, I'm going to silence this chat. I swear. No, you cannot overdose on oxygen, but I know. Well, you can't overdose, but too much could cause some issues in the body. It's a little bit of a fine line there when we talk about that. It's not exactly what we call an overdose, but too much could have some detrimental effects to the body. Become overly oxygen saturated. It can kind of mess with your brain, mess with your mind, cause some drowsiness. So there is a homeostatic level that we do expect on the oxygen, and too much of anything is a bad thing. But no, they don't consider that an overdose exactly, even though it is a drug. Very curious question, though. Very good question. By the way, don't ever say that. I ban that statement. There's no such thing as a dumb question. Every question is a good question. But for the clinical indications, guys, that's going to present as hypoxemia and possible tissue hypoxia. Y'all going to make me have the in class earlier, guys. Hypoxemia and hypoxia are going to be the two clinical indications for oxygen administration specifically.
I have a question. When do we, in what semester or what class do we start getting to the rest of the drugs when it comes to patients?
Say it one more time, Ms. Berry. The audio was
we getting into drugs, like medications that would like. When will we start talking about more drugs other than oxygen?
in this class.
In this class, okay.
Yeah, so we're gonna have a whole chapter on pharmacology.
As well. Yeah.
Yeah, we have a whole chapter on pharmacology. Yes. My least favorite subject when I was in X-ray school. Because when I was in X-ray school, I had to do an entire class on pharmacology. It was a nursing class that we were required to take, and it was a nightmare. So I've taken that and simplified it to just the radiology side of it. It's going to be a lot more pleasant, I promise you. Meanwhile, I'm getting stuff in the chat about flavored oxygen in California. Thank you for sharing that. Now, there are a couple of oxygen devices that you will see most often besides those ones on the wall. There's the portable ones that you see on the left and right here. Sometimes these will be in patient rooms. They work the same way. They're going to deliver that oxygen at a certain level to that patient should their body be requiring a certain percentage of that oxygen. So there are multiple ways we can deliver that in hospitals. And of course, there are the tanks. You guys are most familiar with those. If you have not experienced it already, they are very, very, very heavy if they're full. Sometimes patients will have them hooked onto their wheelchairs, onto their stretchers. Do be very careful with those. And if that patient is supposed to be receiving oxygen, keep an eye out. If that read on that pressure gauge says 0, they're not getting any oxygen, you might want to walk over and turn that up a little bit, make sure they're actually getting that oxygen. But most often they'll have a nurse with them. You'll want to go ahead and inform the nurse in case they do need a certain amount. We don't crank that thing all the way up and be blowing their brain out with oxygen. So preferably, it's something we go ahead and communicate to the nurse so they can get that proper level going. And do keep an eye on that pressure gauge. So be very careful when you're transporting these guys. Probably the biggest mistake I see is these things are not secured properly. So when someone's pushing a wheelchair down the hall, coming to an x-ray room, or on a stretcher, this oxygen tank won't be secured. It falls off, makes a really loud noise, causes a whole bunch of drama. And these things can explode. They're pressurized. I have not seen them personally explode, but I've heard stories of them exploding. And very important point here in oxygen tanks, where is the number one place we would never want to bring one of these into?
MRI room.
The MRI. The MRI room, because they do not make these, as far as I know, MRI safe at all. I don't think they even have like plastic versions of these tanks. If they do, anyone knows about it, please let me know. As far as I know, they're all metal, and there have been deaths, historic deaths in MRI machines because people would bring a patient into an MRI room with an oxygen tank. And if you know anything about the MRIs being those superpowered magnets, the oxygen tank will fly off of that stretcher, fly off that wheelchair like a bullet. And there have been people killed in MRI machines by oxygen tanks because it functioned as a bullet. It impaled the patients. Actual impalation by oxygen tube. Very terrible way to go. Very terrible way to go. So just like I said, guys, very important to check if that oxygen tank is actually functioning, being used before we transport our patients, and make sure it is absolutely 100% secured before you even move that patient one bit. So a few of the other devices that we may use for oxygen delivery, we have two classifications, and we are going to use what's called a nasal cannula. That's the one that goes directly in the nose, little plastic tubes. The face masks that deliver the oxygen. Tents and oxy hoods, exactly what it looks like. It's an actual tent that goes over the patient's bed and delivers a concentrated amount of oxygen to the patients. And the ventilators, and the ventilators are those big, giant machines that you see breathing for your patients. I actually, when I was a child, I had pneumonia twice, and I actually was in the hospital with one of those tents around me. And I always say, one of the funny things is, you ever have one of those memories from your early childhood that just really sticks with you? I think that's my earliest memory. I was 2 years old. And I remember specifically being underneath that tent with my teddy bear. So images never left my mind to this day. Like my earliest childhood memory, one of those things.
My daughter had pneumonia when she was 2 months, and they put something over her face, like, I don't know, it looked like a triangle. And I don't know, I guess they called it something about fast-paced oxygen or fast rate. I don't know, does that make sense?
Does it look like this? No.
It was actually covering her mouth and her nose, but it was like a triangle, and it was like strapped to her head.
Interesting. I'd have to see a picture to know what you're talking about. I'm curious if I've seen that before.
I will look for it. I'm sure I have a picture on my phone. And I'll text it to you.
I'd be curious to see that. So right there, guys, that's your typical nasal cannula. That's going to be the most common oxygen delivery you see on most of your patients. It's giving those small amounts of oxygen to the patient, keeping them regulated. This is going to be for the patients right here that need a little more oxygen delivery at a faster pace. That's going to be your typical face mask that you'll see a lot of patients on. By the way, these masks do show up on x-rays. The cannulas also show up on x-rays. If you're going to move that off the patient, just like with the EKG leads, you need to make sure you communicate with the nurse first. Say, hey, is it okay if I remove the mask before I take the x-ray? Is it okay if I remove the cannula before I take my x-ray, because it will show up in the patient's chest? Those lines are notorious for getting in the patient's chest and obstructing and getting in front of anatomy. So be very careful on that and make sure you communicate. And that's what one of those tents right there would look like. That's the kind I was under when I was a kid. It's literally a tent with a concentrated amount of oxygen. They were trying to clear my lungs because my lungs were full of fluid when I had pneumonia. And I personally have not seen them use these. I don't know if these are obsolete. I can't say it for certain, but I have not seen one of these ever, at least at Texas Children's. So it may be a more obsolete practice. Is that from the 80s? Yes, it was the year 1986. I was born in 84, if you want to know specifically. I was 2 years old, so it was in 86. And of course, our ventilator machines. That is a more advanced ventilator machine. They come in all shapes and sizes. Some of them are quite large and take up the entire room, versus these are a little bit smaller, more portable, and a little less likely to be knocked around if you bring your portable machine in. But like I said earlier, you always want to be extremely careful, because the last thing you want to do is ever bump any of that equipment. And remember, that's keeping most of these people alive. And you knock that loose, you knock that tube loose, the alarm's going to be going off, you're going to be running in, you're going to be saying, get out of here, cussing you out, get out of here, you crazy x-ray tech, you just harmed the patients, and your reputation just took a downturn. So always be very, very careful. So for masks, there are two types. We have what's called aerosol masks and non-rebreathing masks. We utilize both of those for oxygen delivery. That's our two categories, aerosol masks and non-rebreathing masks. Non-rebreathing specifically so you don't rebreathe your carbon dioxide as you're breathing out. It's going to filter that air for you, so you're just getting fresh oxygen. Aerosol, because sometimes they put an actual little aerosol tablet in that mask. You see that little green portion? Sometimes they'll put a little tablet in there to help break up any kind of buildup in the lungs. And that mask will help deliver that directly into the lungs. So it's called an aerosol mask. All right, and with that, I am out of time, guys. I got 2 minutes. I'm going to stop right there. We are almost done with this chapter, and we have one more chapter to go before our next test. Since you guys successfully broke my poker face today, I hope you at least had a good time with the discussion today. Are there any questions about what we talked about today? All right, guys. Well, I do appreciate you. You at least made me laugh today. I will say it's a good job. You made me laugh quite a bit. So go enjoy your lunch, guys. I will see you all at 1:30, and we will dive into the shoulder girdle anatomy. See you all soon. Bye-bye.